So thank you for that introduction, and thank you for having us present today. Um, like Pam said, I'm Glenda, and I'll be presenting the didactic portion of this presentation. When genetics affect chemotherapy, predicting fluoropyrimidine toxicity with DPYD testing. We do not have any disclosures to share. So dihydropyrimidine dehydrogenase, or DPYD, is a gene that encodes the DPD enzyme. The DPD enzyme is the major enzyme responsible for metabolizing fluoropyrimidines to their inactive metabolites. So these include 5-fluorouracil and capecitabine. Systemic fluoropyrimidine chemotherapy is indicated in individuals with gastrointestinal and breast cancers. So someone who has DPD enzyme deficiency will have decreased metabolism of the drug to its inactive metabolites, and this results in increased systemic exposure, therefore increased risk of severe and even fatal toxicity if they're treated with standard doses of fluoropyrimidines. Certain variants in the DPYD gene can result in DPD enzyme deficiency or decreased activity of the enzyme. So in other words, the DPD enzyme has little or no function. In 2024, a group of experts in the field, including those from the Association of Molecular Pathology, published a joint consensus recommendation of DPYD variants that should be included when testing DPYD. The recommended Tier 1 or must test DPYD variants are shown in this table. Column 3 shows the effect that the variant has on the enzyme function, so including no function or decreased function. And the far right column is the associated numerical activity score. Individuals typically have 2 copies of the DPYD gene, 1 copy from each parent. These 2 copies create the genotype, which is then used to predict the phenotype, or the DPYD metabolizer status. This is a table from the Clinical Pharmacogenetics Implementation Consortium DPYD guideline. So if you look first at the third column shown in red, this is a description of the genotype that's used to predict each of the phenotypes that are shown in the first column that's shown in green. The second column in yellow is the combined activity score for the genotype. So a DPYD intermediate metabolizer would have an activity score of 1 or 1.5, and this is the result of having 1 or 2 decreased function variants. And the DPYD poor metabolizers, shown in row 3, have an activity score of 0 or 0.5, and so they have either 1 decreased and 1 no function variant or 2 no function variants. This is a meta-analysis of studies that included patients with solid tumor cancers who received standard dosing of fluoropyrimidine chemotherapy. And they had at least 1 patient with 1 DPYD variant of interest, and the outcome of the study included analysis of the risk of treatment-related mortality. The flowchart on the right of the slide shows that 36 studies were included with a total of 16,005 patients. The arm on the left shows that 3.6% of patients had DPD deficiency, and then the remaining 96.3% on the right arm did not. A total of 27 deaths were attributable to fluoropyrimidine toxicity, with 13 deaths occurring in the DPD deficiency group, which is 2.2% of those who had DPD deficiency. And that's compared to the 14 deaths in those without DPD deficiency, which results in 0.09% of the no DPD deficiency group. And this is just one meta-analysis, but there are many studies that have shown an increased risk of severe toxicity in those with DPD deficiency. In the last couple of years, the FDA labels for fluorouracil and capecitabine have been updated to include text under the warning and precautions section about the risk of DPD deficiency. There's also text that recommends that clinicians should consider DPYD testing prior to initiating fluorouracil. And then there's a section that advises providers to discuss these risks with their patients and then inform them of their testing options. The patient information section of the label shown here, this is for capecitabine, also warns of the risks associated with DPD deficiency and recommends that the patient should discuss DPYD testing with their healthcare provider. In January of this year, the FDA published a safety announcement, and the main intent of this safety announcement was to increase awareness of the fluoropyrimidine label updates that I just showed you related to the risk of DPD deficiency. Additionally, they really stressed that the responsibility is on all healthcare providers to discuss DPD deficiency and testing options with their patients who are intended or going to receive fluoropyrimidine treatment. A few months after that, in March, the National Comprehensive Cancer Network, or NCCN, updated their colon cancer guidelines. And if you look at the bottom of the screen, this is what they updated. So the crossed out text is what the guideline used to say, which was that routine DPYD testing prior to fluoropyrimidine therapy is not recommended at this time. And so they updated the text to what's shown there in yellow, which is that testing for DPYD genetic variants should be considered prior to fluoropyrimidine therapy. And this is big because one of the barriers to providers implementing DPYD testing prior to fluoropyrimidine treatment was that they felt like since it wasn't in the clinical guidelines that maybe it wasn't as important or that they did not need to test prior to treatment. So these updates were really critical in making sure that providers were aware and would start testing prior to treatment. So we've discussed the importance of DPYD testing prior to fluoropyrimidine treatment and then the risks associated with DPD deficiency. So next we'll discuss what do you do with the DPYD results once you have them. The Clinical Pharmacogenetics Implementation Consortium, or CPIC, is an NIH-funded group that facilitates the creation of evidence-based, peer-reviewed guidelines. And then these guidelines are used to help clinicians translate these pharmacogenomic results into medication prescribing actions. Shown here are the recommendations from the DPYD fluoropyrimidine guidelines. So if the patient is an intermediate metabolizer, and you can see what I'm talking about, the recommendations right now are in the red box. If they're an intermediate metabolizer, the recommendation is to reduce the starting dose by 50% and then titrate the dose based on toxicity. This could be up or down. So if the patient doesn't experience toxicity or it's not really clinically significant, you can consider increasing the dose. However, if at the 50% dose reduction, the patient still experiences severe toxicity, then you would want to decrease the dose. On the bottom row, you'll see poor metabolizers. So the overall recommendation is to avoid fluoropyrimidine-based regimens. However, if the patient is a poor metabolizer with an activity score of 0.5, so in other words, they have minimal DPD enzyme activity, and then there's not a suitable alternative to fluoropyrimidine treatment, it is recommended to start with a drastically reduced dose. So reducing the starting dose by at least 75% would be recommended. And so that concludes my portion of today's discussion. But I want to open it up to see if there's any questions before we move on.